Good morning. Welcome to my session, and I'll be presenting the palliative care needs and quality of life among adults with advanced chronic illness in low-income communities in Bangladesh. I am Dr. Md Maruf Hasan, serving at Kurmitola General Hospital in Department of Surgery, and my supervisor is Professor Ahmed Hussain, who is serving at University of Sharjah. So all authors declare no competing interests. So what is palliative care? Palliative care is a specialist treatment approach for patients with severe illness, concentrating on the relieving their symptoms and improving the quality of life both for the patients and their families. Approximately 0.6 million patients in Bangladesh require palliative care, yet less than 4,000 could access it so far. A similar findings was documented among adult cancer patients in Bangladesh. Unfortunately, no previous study have offered comprehensive view of demand for palliative care and the evaluation of quality of life of urban slums residents in Bangladesh. From this perspective, it's high time to explore this gap, especially in low-income groups. Furthermore, we intend to describe the intensity of severe illness-related distress, emphasizing their overall health status in accessibility of the service. So my methodology was, you can say the general objective, which is to assess the need for palliative care and its impact on the quality of life among adults with advanced chronic illness in low-income communities of Bangladesh. And specific objective was to determine the prevalence of palliative care needs among adults with advanced chronic illness in low-income communities using SPICT tool to identify the socio-demographic and clinical factors associated with palliative care needs to evaluate the physical, emotional, social, and spiritual challenges faced by the patients requiring the palliative care, to assess the quality of life across the physical, psychological, social, and environmental domains among the patients with and without palliative care needs, to highlight the disparity in overall quality of life and health satisfaction among patients based on their palliative care needs. So the study design was multi-center cross-sectional study. 4 centers of HMBD Foundation in Mirpur and Tongi was selected, and time frame was February to March in 2023. And the study population was the patient with chronic illness. So sampling technique I'll be showing in the upcoming slide. The sample size was 183. So 553 chronically ill patients were retrieved from the registered book of HMBD Foundation. Following inclusion and exclusion criteria, 278 patients was selected, 275 individuals with advanced chronic illness were invited. 28 denied the participation, 39 were absent, and 18 was unable to speak, and 15 was deceased, and 183 patients enrolled in the study. Following the SPICT, PC trained specialist determined whether the patient requires the palliative care. So inclusion criteria: patient had to be registered as a slum resident, and patient with the following disease, which is diabetes mellitus more than 10 years, and with any organ failure, neurological diseases, COPD or lung diseases, chronic UTI, cancer, liver diseases, a long-time suffering of hypertension, and multimorbid patients. And the disabled patient with any disease was included, and dementia was excluded. The data collection tool, we used African Palliative Outcome Scale, the supportive and palliative care indicator tool, that is SPICT, and ECOG scale for performance status, WHO QOL. BRIEF was used. The statistical analysis was done using the software R, and Gemini was used for the analysis. The ethical consideration, the approval was taken from BMRC in January 2022, and all participants were taken the consent from the consent was taken from them, and they had the freedom to withdraw from the study at any moment of the study. So the result and findings, you can see among the patient with advanced stage disease, 31.1% required palliative care. The highest needs was observed in patient with neurological disease, followed by COPD and long-term diabetes with organ failure, and the median duration of the illness was palliative care needing patient was 6 years. Older adult with more than 60 years of age had a significantly higher likelihood requiring palliative care compared to the young age group. The disability prevalence was 45% among the patient needing palliative care compared to the 15% those not required palliative care. Functional status showed that 74% of the palliative care needing patient were bedridden and had limited activity versus 25% in others. Gender was not a significant factor in palliative care needs. So 85% patient reported moderate to severe pain, and 60% patients suffered from emotional distress, which is anxiety and depression. Social distress was significant in 50% cases, often linked to financial instability and family caregiving burdens. 40% expressed unmet spiritual needs, especially concerned about dignity and end-of-life preparation. Physical domain scores were 45% lower in PC needing patient compared to those without palliative care need, and a psychological score were 35% lower with severe emotional distress in primary factor. Social domain scores showed 50% deficit due to lack of support and financial insecurities. Environmental domain scores were 40% lower and highlighted poor living condition and limited access to the healthcare services. Only 15% of palliative care needing patient related to the overall health as satisfactory compared to 65% of those not required palliative care. The health satisfaction score among palliative care needing patient were significantly influenced by the access of medication and family support. So you can see among the cancer patient, 87.5% were identified as needing of palliative care, while 53.3% patient with chronic kidney disease required it. So in the table, you can see a very bizarre findings in number 6, feeling at peace, that a huge number of patients were feeling at peace, even they were identified with that they were needing palliative care because they have accepted their situation considering the socio-demographic and political situation of our country. So you can see the ECOG performance stage score, you can see the gender was not a factor, and higher age group needed it more, and the ECOG performance in higher the score, higher the need of palliative care, and in disabled group it was higher. And finally, it was a multi-sectoral cross-sectional study, so which captures the data at a single point of time, and it limits the ability to causal interference regarding the relationship between the chronic illness and quality of life, and the study sample size and the demographic diversity may limit the generalizability of the study. And finally, I would like to conclude with one thing, that we need to include this urgent integrated palliative care into primary healthcare service and formulating policies, because in upcoming operational plan, in the 5th operational plan, we don't have any provision for palliative care in our non-communicable disease operational plan. So if we can include this palliative care part in our operational plan, it will be very much helpful for our patient with this kind of long-term diseases. So thank you all. Thank you for your patience hearing.